A deep dive into the world of anesthesia monitoring. We're taking a look at all the essentials, both cardiovascular and non-cardiovascular.
Sounds good to me.
We're using a bunch of resources for this, Anesthesia Academy Session 2, Chapters 5 and 6 of the Morgan textbook. And to spice things up a bit, some past exam paper highlights too.
Always good for a refresher.
Definitely. And considering our audience is medical professionals, we can dive right into the meat of it. No need for a basic physiology recap.
Agreed.
So let's kick things off with arterial blood pressure monitoring. It seems straightforward, but what nuances do we see in the operating room that we wouldn't necessarily encounter in a regular clinic setting?
Let's see. One thing that comes to mind is patients with severe peripheral vascular disease.
Yeah.
The distortion of that peripheral pulse pressure, it can make a big difference.
Wow, so it's really important to understand not just how we're getting the blood pressure, but why.
Exactly. We can't just rely on a number. We have to interpret it in the context of the patient.
Makes sense. Now, there are a bunch of different ways to monitor blood pressure, both invasive and non-invasive.
Right.
Starting with the non-invasive, we have palpation, which is the simplest, but it only gives us that systolic pressure, right?
Right.
Then there's the Doppler probe, which is useful in tricky situations, like with obese patients.
Yeah, or pediatric patients.
Right, exactly.
Yeah.
And of course, the classic auscultation method with the stethoscope.
Can't forget that one. It's still widely used, reliable, but can be tricky in noisy environments.
For sure. We also have oscillometry, which is what those automatic cuffs use. Convenient, but I've noticed they can be less reliable in patients with arrhythmias or severe hypotension.
Definitely. And then there's arterial tonometry.
Yeah, what's that all about?
Well, it directly measures arterial wall tension. It's super accurate and offers continuous monitoring, but, not very common.
I can see why. It sounds pretty complex.
It is. It requires specialized equipment.
So we've got a whole toolkit for non-invasive blood pressure monitoring. But when do we absolutely need to go invasive?
Good question. Invasive monitoring using an arterial catheter becomes essential in major surgeries, or those critical care situations.
I see, where blood pressure can fluctuate rapidly.
Exactly. We need that real-time, beat-to-beat accuracy to guide our decisions.
And we might need frequent blood gas analysis, too.
No, wait.
So tell me about those preferred sites for arterial lines. Why is the radial artery so popular?
Well, the radial artery, it's easily accessible and has good collateral circulation, which we confirm with the Allen's test.
Makes sense. Minimizing the risk of compromising blood flow to the hand.
Right. But keep in mind, the Allen's test isn't foolproof.
Good point. What about the brachial artery?
The brachial. It's another option, but prone to kinking.
And the femoral?
The femoral artery, it's larger, easy to access, but carries a higher risk of complications like thrombosis.
So choosing the right site is a balancing act, considering both access and potential complications.
It always is.
Now let's decode those arterial waveforms. What secrets are they hiding?
Think of the waveform as a story.
Okay, I like that.
The rate of upstroke tells us about contractility. A steep rise means a strong heart.
Interesting.
A slower downstroke can hint at higher peripheral resistance.
Got it.
And then there are those subtle respiratory variations. They can reveal volumes about the patient's fluid status. Significant changes could mean hypovolemia, even cardiac tamponade.
Oh, wow, it's like a hidden language.
Yeah.
But we can't forget about the equipment itself, right? Frequency response, damping coefficient, transducers. All these factors can impact our readings.
Oh, you're absolutely right. A well-calibrated system, it's like having a finely tuned instrument.
For sure.
Think of the damping coefficient as like shock absorbers on a car. Too stiff, you miss the bumps.
I see.
Too loose, it's a bumpy ride. We aim for that sweet spot.
Okay, and what about transducer positioning?
Transducers, zeroed at the phlebostatic axis.
Right, the patient's mid-axillary line.
Exactly. It's all about precision.
Makes sense. Yeah. Now, moving on to central venous catheterization. This is particularly important in critical care, isn't it?
You bet. Central venous access, it's like a direct line to the heart's right side. Gives us insights, treatment options, all sorts of things.
Incredible. So we use it for CVP monitoring, rapid fluid resuscitation, giving medications that would irritate peripheral veins. It's a very versatile tool. But are there situations where we'd avoid placing a central line?
Oh, definitely. Coagulopathy, infection at the site, those are major red flags.
Right.
We don't want to increase bleeding risk or introduce pathogens.
Okay, makes sense. Now, let's talk about the different insertion sites. There are quite a few, each with its own pros and cons.
Absolutely.
Why is the subclavian vein often the preferred site for longer-term access?
Well, it's tucked away, right? Lower risk of infection,
But gotta?
but not ideal for patients on anticoagulants. Can't directly compress it if there's an arterial puncture.
That's a good point.
Internal jugular, especially on the right, provides a straighter shot to the SVC.
Mhm.
Femoral vein, it's easy to access, but higher risk of thrombosis and infection.
So choosing the site is a strategic decision, considering the patient's needs, the clinical context.
Exactly. And as with any procedure, potential complications.
Right, infection, thrombosis, even air embolism.
Right. That's why we need meticulous technique and vigilant monitoring.
Now, the CVP waveform, it can be tricky to interpret, but it's a goldmine of information about the heart's right side, isn't it?
It is. It's like a secret code revealing the heart's inner workings. Each peak, each valley tells a story.
So the A wave, I remember that one. It signals atrial contraction.
Exactly. Absent in atrial fibrillation, by the way.
Right, good point.
A prominent X descent could be a sign of cardiac tamponade.
And Lardev waves.
Could point towards tricuspid regurgitation. It's about connecting the dots, understanding the physiology.
So we're essentially getting a real-time echocardiogram, in a way. Next up, pulmonary artery catheterization. This one is reserved for more complex cases, right? When would we choose this over less invasive monitoring?
You're right, reserved for the more complex cases. PAS, pulmonary artery catheterization, it's like our heavy artillery. We use it when less invasive monitoring isn't enough.
I see, like for severe shock, refractory heart failure, complex cardiac surgeries.
Exactly. It gives us detailed information. Pulmonary artery pressures, wedge pressure reflecting left atrial pressure, even direct cardiac output measurements.
The ultimate diagnostic tool. But I imagine with its invasive nature, there are considerations, contraindications.
Of course, of course. Left bundle branch block, for instance, can be tricky.
Why is that?
We worry about inducing complete heart block during insertion.
Okay, that makes sense.
Patients with arrhythmogenic conditions or pulmonary hypertension, those require extra caution too. Higher risk of arrhythmias and pulmonary artery rupture.
So weighing the benefits against the risks. Choosing the most appropriate monitoring strategy for each patient.
Every time.
Now, once the PAIC is in, continuous vigilance is key.
Absolutely.
Those clicks can migrate, causing complications.
You're right. Pulmonary infarction, even artery rupture. We need to be hawk-eyed during insertion, watching for over-wedging.
Over-wedging.
Yeah, where the catheter tip occludes the pulmonary artery. We need to be proactive, anticipating potential problems.
And even with perfect technique, some factors can affect the accuracy of our readings.
That's right. Something as simple as injection technique during thermodilution measurements, it can skew cardiac output readings.
Really?
Yeah. Consistent volume, rate, and temperature of the injectate are crucial. We also need to be aware of interference from things like electrocautery. It's a delicate balance.
A lot to consider.
Yeah.
Okay, let's shift gears now. We have various ways to measure cardiac output, each with its strengths and weaknesses.
Exactly. Thermodilution, for example, uses temperature changes to calculate cardiac output. Reliable with the pack, but certain conditions can throw it off.
Like tricuspid regurgitation or intracardiac shunts.
Right.
What about dye dilution?
Dye dilution. It's a good alternative when thermodilution isn't ideal, but it's invasive, requires blood sampling. Slower results.
Got it. Then we have pulse contour analysis. Less invasive. How does that one work?
Pulse contour analysis, it's like a detective. It uses algorithms to analyze the arterial pressure waveform.
Interesting.
The shape of the waveform. It estimates stroke volume and ultimately cardiac output.
I see. Less invasive continuous data. But what about its accuracy?
Accuracy can be affected by things like changes in vascular tone and compliance.
So a valuable tool, but we need to be aware of its limitations. What about esophageal Doppler?
Esophageal Doppler. It's minimally invasive, useful in the perioperative setting. It uses an ultrasound probe in the esophagus to measure blood flow velocity in the descending aorta. Real-time data, but operator-dependent, and only estimates a portion of the cardiac output.
So many choices. Thoracic bioimpedance is another option, isn't it?
Yeah, non-invasive, convenient. It measures changes in thoracic electrical impedance caused by aortic blood flow. But conditions like pulmonary edema, they can skew the results.
And of course, we have echocardiography, the gold standard. But it's not continuous, requires a skilled sonographer.
You got it.
So many ways to assess cardiac output. Choosing the right tool for the job is key. Now, on to another cornerstone of monitoring, electrocardiography.
Ah, yes, the ECG. Continuous information about the heart's electrical activity. essential for detecting arrhythmias and ischemia in real time.
We have different leads to choose from, each giving us a different view of the heart. Lead 2, for example.
Lead 2, it's our go-to for detecting arrhythmias.
Like atrial fibrillation.
And inferior wall ischemia.
What about lead V5?
Lead V5, that's our window to the anterior and lateral walls. Good at picking up ischemia in those regions.
Interesting. And then there's the modified V5, CS5. What's the advantage of that one?
CS5 enhances detection of anterior wall ischemia without needing a full 12-lead setup. Just move the left arm electrode to the V5 position.
Clever. And the ST segment, it's a critical area to analyze on the ECG.
It is. The ST segment, it's like a barometer of myocardial oxygen supply and demand. ST depression, that's a sign of ischemia. ST elevation can indicate acute injury.
And we need to make sure we're in diagnostic mode to get an accurate representation of the ST segment.
You bet. Those filters and settings, they can distort the signal, and calibration is key.
A 1 millivolt signal should produce a 10 millimeter deflection on the ECG strip.
Exactly. It ensures accurate comparisons across different monitors.
So many details matter.
Yeah.
Now, let's move on to pulse oximetry. It's become a standard of care, but tell me about the science behind it.
Pulse oximetry, it's all about the interaction of light and hemoglobin.
Okay.
Think of the sensor as a tiny detective, shining red and infrared light through the tissue.
Interesting.
Oxygenated and deoxygenated hemoglobin, they absorb these light differently. The device calculates the percentage of hemoglobin carrying oxygen, which is our SpO2 reading.
Very clever. And why is this so clinically important?
Well, a drop in SpO2, it can be the first sign of hypoxemia, an early warning system for respiratory compromise.
But I'm guessing there are situations where even the pulse oximeter can be fooled.
There are. Carbon monoxide, for example.
Yeah.
It binds to hemoglobin even more avidly than oxygen, creates carboxyhemoglobin.
Right.
It absorbs red light similarly to oxyhemoglobin. This can give a falsely reassuring SpO2 reading even when the patient is severely hypoxic.
That's a scary thought. So we can't rely solely on technology. The clinical context is crucial.
Absolutely. And there are other things that can throw off readings too. Methemoglobinemia, dyes, motion artifacts, low perfusion states.
Yeah.
We need to be aware of these pitfalls.
It's like a constant game of detective work. Okay, moving on to non-cardiovascular monitoring. Capnography. It's a tool that seems simple but tells us a lot about both ventilation and circulation.
Oh, it's a fantastic tool. It gives us a real-time window into the respiratory cycle.
I've always been fascinated by how much information we can get from something as simple as breathing. How does it actually work?
Well, we're measuring CO2 and exhaled breath, and we do this by leveraging infrared light absorption, shining a light through exhaled breath. CO2 molecules, they absorb infrared light at a specific wavelength. More CO2, less light gets through. The capnograph measures this and gives us that familiar waveform.
The peaks representing exhalation and the valleys, inhalation.
Exactly.
I know we have different types of capnographs, non-diverting and diverting. What are the key differences?
Non-diverting or mainstream, they have a sensor directly in the airway. Fast, accurate readings.
Okay.
But they're bulkier, often more expensive.
Got it. And the diverting or side stream?
They sample a bit of gas from the circuit. More compact, but can be affected by things like water condensation.
Right. And I know the aspiration rate plays a role too.
It does. Higher rates improve response time, but can dilute readings in patients with small tidal volumes. Lower rates, they might underestimate CO2 during rapid ventilation. It's about finding that balance.
So when interpreting the capnograph, what's the significance of that PaNO2 and EtCO2 gradient?
Normally, PaNO2, the CO2 in arterial blood, is slightly higher than EtCO2 and tidal CO2 because of dead space in the lungs. But a widening gap between the two, that can be a red flag. Could mean ventilation perfusion mismatch or increased dead space.
Interesting. It's incredible how much we can learn from just exhaled breath. Okay, shifting gears a bit. Let's talk about urinary output.
Sure.
It seems basic, but it tells us so much about the patient's overall physiological state.
Right. Urinary output, it's a window into volume status, renal function, and organ perfusion.
And what constitutes oliguria, and why should we be concerned if we see it?
Oliguria, that's less than 0.5 milliliters of urine output per kilogram of body weight per hour. It can be a sign of trouble. Could be hypovolemia, decreased renal perfusion, even acute kidney injury.
A drop in urine output, it's definitely a call to action. And I've always been curious about bladder decompression causing hypotension. Why does that happen?
Well, rapid decompression of a distended bladder can cause a sudden drop in blood pressure.
Why is that?
Likely due to a decrease in sympathetic tone or a vasovagal response.
So it's something to be mindful of. Gradual decompression is the way to go.
Definitely. No sudden hemodynamic roller coasters.
Speaking of avoiding roller coasters, let's delve into peripheral nerve stimulation, essential when using muscle relaxants.
Absolutely essential. It's our communication system with the neuromuscular junction. Helps us assess the depth of neuromuscular blockade, guide our dosing of muscle relaxants, make sure the patient wakes up breathing comfortably.
It sounds like a delicate balance.
It is.
Can you walk me through how it works? What are we actually doing when we stimulate a peripheral nerve?
Well, we're delivering controlled electrical impulses to a nerve using a nerve stimulator. It's a tiny zap, makes the muscles twitch. And by analyzing those twitches, we can gauge how much the muscle relaxant is affecting the neuromuscular junction.
And we can use different types of stimuli, each revealing different information,
That's right.
like the train of four, TOF.
TOF is our workhorse. 4 quick pulses, watch how the muscle responds. We're looking for fade, a decrease in the strength of the twitches. More fade, deeper the block.
So the muscle gets tired.
In a way, yeah. And we quantify that fade with the TOF ratio.
Right, the amplitude of the fourth twitch divided by the amplitude of the first.
Exactly. A ratio of 1 means no fade, while 0 means complete block.
So we're not just looking at whether the muscle twitches, but how those twitches change over time. What other stimulation patterns are there?
Well, we use single twitch to establish a baseline. Tetanic, a continuous high-frequency stimulation that's more for research, can be uncomfortable.
Makes sense.
And then there's double burst stimulation, DBS.
Right.
DBS is like TOF's more sensitive cousin. Good at detecting residual block. We often use it to confirm recovery before extubation.
So many options. Is there a pattern to how different muscle groups recover from neuromuscular blockade?
There is. The diaphragm, the rectus abdominis muscles, they tend to recover first.
Okay, so the ones most important for breathing.
Right. Then the laryngeal adductors, protecting the airway. The orbicularis oculi, responsible for eye closure. The peripheral muscles, like those in the hands and feet, they're last.
It's like the body prioritizes the muscles essential for survival. What clinical signs do we look for before extubation?
We want to see a strong head lift for at least 5 seconds, good grip strength, ability to generate an inspiratory pressure of at least negative 25 centimeters of water.
Okay, so signs that the patient has enough muscle strength to breathe on their own. Now let's talk about the Pin Index Safety System, PISS. Can you remind me of the main purpose of this system and why it's so important?
Imagine the chaos if we accidentally hooked up the wrong gas cylinder. That's where PISS comes in, preventing mix-ups. Each gas has its own pin arrangement, like a lock and key.
So it's a mechanical safeguard against human error. What other essential safety features should we talk about?
Well, the emergency oxygen flush valve is crucial. It delivers a high flow of pure oxygen directly to the breathing circuit, a lifeline in emergencies.
Got it.
And then there's Barolime. It's our CO2 scrubber, removes CO2 from the exhaled breath, keeps the breathing circuit fresh.
Okay, let's shift gears to preoperative evaluation. I'm interested in the concept of metabolic equivalence, or METs. How does this translate to our pre-op assessment?
METs are like a fitness score. They tell us how much oxygen the patient consumes during various activities. One MET is the resting metabolic rate. Climbing stairs, walking uphill, those are about 4 MET.
So higher METs mean a fitter patient.
Generally, yes. And it's important pre-op because patients with low MET scores might have limited functional capacity, higher risk of complications.
So we can anticipate challenges, tailor our anesthetic plan.
Exactly.
What about patients who've had a recent myocardial infarction? Any specific considerations there?
We generally postpone elective surgery for at least 6 weeks after an MI.
Because?
Risk of reinfarction is much higher during that time. Give the heart time to heal.
Makes sense. Okay, let's talk about airway management. Specifically, assessing mouth opening. How does this factor into our pre-op evaluation?
Mouth opening, it's the gateway to the airway. We measure the interincisor distance, the space between the upper and lower incisors.
Right.
Normal range is about 4 to 6 centimeters. A restricted opening can make intubation tough.
So it's one of those subtle signs we pay attention to during our pre-op assessment. What about MRI compatibility of anesthesia equipment?
Safety in the MRI suite is paramount. Those powerful magnetic fields, they can interfere with equipment.
For sure.
We have 3 classifications: MR safe, MR conditional, and MR unsafe.
And what do those mean?
MR safe, it's good to go in any MRI environment. MR conditional, it's safe under specific conditions. And MR unsafe, it's a no-go, poses a hazard.
So we need to carefully select equipment that's been tested and deemed safe for the MRI environment. Now, back to cardiovascular monitoring, the jugular venous pressure waveform, or JVP. How does it complement the CVP waveform?
The JVP waveform, it's like the CVP's less invasive cousin. It gives us a non-invasive way to assess those pressure changes in the right atrium.
Another way to peek into the heart's right side. And like the CVP waveform, each peak and valley has meaning.
Exactly. The A wave, for instance, it reflects atrial contraction.
Right.
Can be prominent in conditions like tricuspid stenosis. We might also see Canon A waves in cases of AV dissociation.
And what about the C wave?
The C wave, it's a subtle bump caused by the tricuspid valve bulging into the right atrium during ventricular contraction.
Okay.
Marks the onset of ventricular systole and can be prominent in tricuspid regurgitation.
What about the X descent?
The X descent shows atrial relaxation during ventricular systole, absent in tricuspid regurgitation and right heart failure.
Interesting. And the Vive wave?
The V wave, it appears during isovolumic relaxation, represents atrial filling against a closed tricuspid valve, prominent in tricuspid regurgitation.
Got it. And finally, the Y descent.
The Y descent, it marks the opening of the tricuspid valve and the passive emptying of the atrium. Can be absent or blunted in cardiac tamponade or prominent in constrictive pericarditis.
So much information packed into those subtle fluctuations. Okay, let's move on to a classic, listening to heart sounds.
Ah, yes, a symphony of sounds, each beat revealing a story about the heart's function.
And we usually hear two main sounds, S1 and S2. What do they represent?
S1, the first heart sound, is the sound of the mitral and tricuspid valves closing. It marks the beginning of systole, the lub in lub dub.
And S2, the dub.
S2 is the closure of the aortic and pulmonary valves, marks the end of systole and the beginning of diastole. Best heard at the base of the heart.
Okay, and then we have the extra hard sounds, S3 and S4. What do those tell us?
S3, sometimes called a ventricular gallop, is an early diastolic sound right after S2,
Okay.
caused by rapid ventricular filling. Normal in children and pregnant women, but in adults, it can be a sign of volume overload.
So it can be either physiological or pathological.
Exactly. S4, or an atrial gallop, is a late diastolic sound just before S1, caused by atrial contraction pushing blood into a stiff ventricle, generally considered abnormal in adults.
So a sign of decreased ventricular compliance.
Right. Seen in conditions like left ventricular hypertrophy or ischemia.
And speaking of S2, what about S2 splitting? What causes it?
S2 splitting happens because the aortic and pulmonary valves don't always close simultaneously. During inspiration, the pressure changes cause more blood to flow into the right side of the heart, delaying the closure of the pulmonary valve. Creates a split S2.
And the splitting varies with breathing.
It does. Normal splitting widens during inspiration, narrows during expiration, but some conditions can cause abnormal splitting patterns.
Interesting. Like what?
A wide, fixed split, it can indicate an atrial septal defect.
Okay.
A paradoxical split, wider during expiration, could be a sign of left bundle branch block or aortic stenosis.
Wow. Even subtle variations in S2 splitting can give us clues. Now let's talk about murmurs. I know they often indicate turbulent blood flow. What should we know about them?
Murmurs are like whispers, each telling a story about the heart valves. We classify them based on timing, intensity, and location. That helps us pinpoint the problem.
Makes sense. What would an aortic stenosis murmur sound like, for example?
Aortic stenosis creates a harsh crescendo-decrescendo murmur during systole, often radiates to the carotid arteries.
Got it. And what about mitral regurgitation?
Mitral regurgitation produces a holosystolic murmur, meaning it spans the entire duration of systole.
And where is it best heard?
At the apex, often radiating to the axilla.
Okay. So each murmur has its own signature. What about mitral stenosis?
Mitral stenosis creates a low-pitched, rumbling, diastolic murmur, often preceded by an opening snap.
Interesting.
Listening in the left lateral decubitus position can accentuate it.
What about aortic regurgitation?
Aortic regurgitation produces a high-pitched, blowing decrescendo murmur that starts right after S2, often heard along the left sternal border.
Okay. And tricuspid regurgitation?
Tricuspid regurgitation produces a holosystolic murmur that intensifies during inspiration. We call that Carvalho's sign.
Interesting.
Frequently seen in right heart failure, also associated with endocarditis and IV drug users.
Right. And pulmonic stenosis?
Pulmonic stenosis creates a systolic crescendo-decrescendo murmur best heard at the left upper sternal border, often a congenital condition.
So we might see it more in younger patients.
Right.
Now, what about hypertrophic cardiomyopathy? What's unique about the murmur associated with that condition?
Hypertrophic cardiomyopathy, or HOCM, is characterized by thickening of the heart muscle, particularly the left ventricle. In the obstructive type, it can obstruct blood flow, creating a systolic ejection murmur that actually intensifies with maneuvers that decrease preload.
Like the Valsalva maneuver.
Exactly.
Incredible. So much information from listening to the heart. Now let's quickly review normal hemodynamic values for different parts of the cardiovascular system.
Sure. Understanding those pressure gradients helps us make sense of everything.
Okay, starting with the right atrium.
Right atrium. Normal pressure, reflected in the CVP, is 3 to 8 millimilli Hg.
Right ventricle.
Systolic pressure is 15 to 25 millimilli Hg. Diastolic, same as the CVP, around 3 to 8.
Pulmonary artery.
Systolic pressure, similar to the right ventricle, 15 to 25. Diastolic slightly higher, 8 to 15. Mean pressure, usually between 10 and 20.
PCWP.
The PCWP, or pulmonary capillary wedge pressure, is usually between 2 and 15. It reflects the left atrial pressure, so it helps us assess left heart filling pressures.
Fascinating.
And the left ventricle.
Yeah.
Systolic pressure, what we measure as systemic blood pressure, is 100 to 140. Diastolic is much lower, 3 to 12.
And finally, systemic arterial pressure.
The normal range, 100 to 140 systolic, 60 to 90 diastolic. Mean arterial pressure, or MAP, is usually between 70 and 105.
It's like a pressure map of the entire circulatory system. Understanding those normal values is crucial. Okay, let's move on to temperature regulation.
Sounds good.
Maintaining normothermia, or normal body temperature, it's super important, especially for longer procedures. Hypothermia can trigger a cascade of negative effects.
Absolutely.
And it's more than just patient comfort, right?
Oh, much more.
Hypothermia increases bleeding risk, slows down metabolism and drug clearance, and it can suppress the immune system.
Wow, it's like a domino effect. And hyperthermia, or high body temperature, that's a problem too, isn't it? It is. Hyperthermia increases metabolic demands, can lead to tissue damage, even seizures. We need to find that balance.
So how do we monitor temperature during anesthesia? We have a variety of thermometers, but what are the pros and cons of each?
Skin temperature probes are simple but less accurate.
Right, because skin temperature is influenced by ambient temperature and blood flow.
Exactly. Esophageal probes are more accurate but require careful positioning.
Makes sense.
Bladder probes are an option, but urine output and irrigation can affect the readings. And then there are core temperature monitors.
Those are the most accurate, right?
They are, but also the most invasive.
So choosing the right tool depends on the patient and the situation.
Always does.
Okay, now let's talk about patient positioning.
Okay.
It's often overlooked, but it's crucial for patient safety during surgery.
Absolutely. It's a shared responsibility to make sure the patient is safe and comfortable.
And there's so many different positions.
We have the supine position, the prone position, the lateral decubitus position.
Right, each tailored to a specific type of surgery.
Exactly. The lithotomy position for gynecological and urological procedures. The Trendelenburg, where the patient is tilted head down. Each designed to optimize surgical access and protect the patient.
And each position has its own considerations, potential pitfalls.
For sure. Pressure points, nerve pathways, ventilation, circulation, we need to think about it all.
So many things to keep in mind.
In the prone position, for example, we have to make sure the chest can expand freely for the patient to breathe.
Right.
In lithotomy, avoid overextending the legs. Can stretch nerves.
It's a lot to keep track of.
It is. It is. Communication is key. The whole team needs to be on the same page.
Okay, let's talk about fluid management. Maintaining the right balance during surgery.
Yeah, fluids are crucial.
Yeah.
Too little and you have dehydration and poor perfusion. Too much and you risk overloading the circulatory system. It's all about that balance.
So how do we determine fluid needs during surgery? What factors do we consider?
We look at their baseline fluid status, the type of surgery, how long it will take, estimated blood loss, urine output.
Right, and we use clinical signs too.
Of course, heart rate, blood pressure, capillary refill, those all give us clues.
It's like putting together a puzzle, a personalized fluid plan for each patient.
Exactly. And we have different types of fluids we can use.
Yeah, crystalloids and colloids.
Crystalloids like normal saline, lactated ringers, and plasmolite. They're good for replacing routine fluid losses.
And colloids.
Colloids, like albumin, dextrin, and hydroxyethyl starch, we use those for patients who are hypovolemic or at risk of becoming hypovolemic.
They help expand blood volume quickly, so we've got options.
Yeah.
But sometimes fluids aren't enough, and we need to think about blood transfusion.
Right, blood transfusion, it's a life-saving intervention, but not without risks.
We have to weigh the benefits against the potential complications.
Exactly. Transfusion reactions, infections, immunosuppression.
So when do we decide a transfusion is necessary?
Well, we look at the patient's hemoglobin level, signs of anemia, estimated blood loss, the nature of the surgery.
Right, and their overall health status, too.
Of course. And we have different blood products, too. Packed red blood cells, platelets, fresh frozen plasma.
Each one with a specific purpose.
That's right. It's about giving the right product for the specific deficiency.
Now, let's talk about depth of anesthesia monitoring. Ensuring the patient is adequately anesthetized, but not oversedated.
It's a delicate balance, for sure. Traditionally, we've relied on those clinical signs: heart rate, blood pressure, respiratory rate, movement.
But those can be influenced by other things too, right? Like pain, surgical stress.
You're right. So we have to consider the whole picture. And in recent years, we've seen the emergence of brain function monitors.
Brain function monitors, or processed EEG monitors, they give us a more direct look at brain activity. How do those work?
They use electrodes placed on the forehead to measure electrical activity. Then a computer processes that signal and generates a number, the BIS value, that reflects the depth of anesthesia.
So, a numerical scale for consciousness. And what's the ideal BIS range for general anesthesia?
We typically aim for 40 to 60. 100 means fully awake, while 0 means no electrical activity. It's not perfect, but it's a valuable tool.
Especially in procedures where awareness under anesthesia is a concern.
Right, like cardiac surgery or trauma surgery.
There's another layer of safety for our patients. Okay, let's talk about postoperative pain management.
Sounds good.
Effective pain management. It's so crucial for recovery.
It is. Uncontrolled pain delays healing, increases complications, can even lead to chronic pain.
So it's not just about comfort. It's about optimizing recovery. What approaches do we use?
We have a range of tools. Simple analgesics like acetaminophen and ibuprofen, opioids like morphine and fentanyl, regional anesthesia techniques like nerve blocks and epidurals, and increasingly multimodal analgesia, combining different techniques.
A multi-pronged attack on pain. And the choice of strategy depends on the patient and the surgery, right?
Of course. We consider their age, weight, allergies, medical history, pain tolerance, and patient education is important too.
Right, empowering them to participate in their pain management plan.
Exactly.
Okay, as we start to wrap up this deep dive, let's revisit some key safety principles.
Sounds good to me.
What are some fundamental things we always keep in mind to ensure patient safety?
Well, safety is paramount, right? So we start with a thorough pre-anesthetic assessment. We use checklists religiously, communication is key, and we cultivate a culture of vigilance, constantly monitoring our patients, adapting to changes.
It's a multifaceted approach, requiring attention to detail, a deep understanding of physiology, and teamwork.
You're absolutely right. And while technology is great, it's our clinical judgment, expertise, and commitment to our patients that truly make a difference.
Okay, shifting gears now to neuromuscular monitoring. This is especially important when we're using muscle relaxants.
Absolutely. Muscle relaxants are powerful tools, but we need to monitor their effects carefully to make sure the patient can breathe safely afterward.
It's a delicate balance, achieving muscle relaxation while ensuring safe recovery. How do we navigate that?
Neuromuscular monitoring is key. We use a nerve stimulator, delivers electrical impulses to a peripheral nerve,
Right.
causes the muscles to contract. By analyzing those contractions, we can figure out the level of neuromuscular blockade.
So it's like testing the circuit to see how much signal is getting through.
That's a good way to put it. We're assessing how wide the nerve impulse is being transmitted to the muscle. And we use different stimulation patterns, each with its own purpose. The train of 4, TOF, that's our bread and butter.
Right, 4 stimuli over 2 seconds.
Exactly. And we look for fade, which is a decrease in the strength of the twitches with each stimulus. More fade means a deeper level of paralysis.
So we're paying attention to the pattern of the twitches.
That's right. We use the TOF ratio to quantify the level of blockade. A ratio of 1 means no fade. Closer to 0 means deeper paralysis.
Yeah, we have other stimulation patterns like single twitch, tetanic, and double burst.
Single twitch for baseline assessment. Tetanic, mostly for research. Double burst, DBS, it's more sensitive than TOF, helpful for confirming recovery before extubation.
So many tools to help us manage neuromuscular blockade. What are our main goals?
Adequate paralysis during surgery, smooth intubation, and preventing complications from both inadequate and excessive blockade.
It's about finding that sweet spot.
Exactly.
Now let's talk about BIS monitoring. It helps us assess depth of anesthesia by analyzing brain activity.
Right. It's like having a window into the patient's level of consciousness. We measure electrical signals in the brain, and a computer processes the signal and gives us a number, the BIS value.
So it quantifies how deeply asleep the patient is. What's the ideal range?
For general anesthesia, usually 40 to 60, 100 is fully awake, and 0 is complete silence. It's not a perfect tool, but is very helpful.
Especially when we're concerned about awareness under anesthesia.
Yeah.
Okay, let's shift gears again and talk about airway management, the most fundamental aspect of anesthesia care. We're talking about making sure the patient has a clear and open airway so they can breathe.
Absolutely. It's crucial. And sometimes we encounter difficult airways, which can make things more challenging.
Difficult airways, what makes them difficult?
Well, certain anatomical features can make intubation more difficult. Things like a small mouth opening, a receding jaw, a large tongue, a short neck.
So we need to recognize these potential difficulties beforehand.
During our preoperative assessment, yes. We carefully examine the airway, assess neck mobility, consider the patient's medical history.
And if we anticipate a difficult airway, how do we prepare?
We have several options. Different types of laryngoscopes. Video laryngoscopy can be very helpful, fiber optic intubation, and sometimes we even do awake intubation.
Awake intubation, where the patient is awake while we secure the airway.
Exactly. It's not always necessary, but it can be the safest option in some cases.
So, airway management is a complex skill requiring experience and adaptability. What about mechanical ventilation? We often use it to breathe for the patient during surgery. What are the key principles?
Mechanical ventilation helps the patient's lungs. We use a ventilator to deliver oxygen and anesthetic gases, and we adjust the settings carefully to meet the patient's needs.
Like the tidal volume, respiratory rate, and fraction of inspired oxygen.
Exactly. We also adjust the inspiratory pressure and flow. We want to make sure the lungs are adequately inflated but don't cause any damage.
And what about complications of mechanical ventilation?
Well, we always need to watch for things like barotrauma, damage from high airway pressures, volutrauma, damage from excessive tidal volumes, and ventilator-associated pneumonia, VAP.
It's a powerful tool that can save lives, but we have to be very careful. Okay, let's talk about regional anesthesia, like nerve blocks and epidurals.
Regional anesthesia is a fantastic way to manage pain. It blocks pain signals from a specific region of the body.
And what are the advantages?
Excellent pain control, often better than systemic medications, lower opioid requirements, faster recovery. And it can be safer for patients with certain health conditions who might not tolerate general anesthesia well.
So it's a good option for many patients. And there are many different regional techniques, right?
We have peripheral nerve blocks, epidurals, and spinal anesthesia. Each one has its own specific uses, benefits, and risks.
How do we decide which technique is best?
It depends on the surgery, the patient's anatomy, their medical history, their preferences. We have to consider all of these things.
And like any procedure, regional anesthesia has risks.
Yes, there are risks of bleeding, infection, nerve damage, and systemic toxicity from the local anesthetic. But with careful technique and monitoring, we can minimize these risks.
Okay, let's move on to monitoring during recovery.
Yeah.
What are we watching for as patients wake up from anesthesia?
We're making sure they're transitioning back to their normal state. We monitor vital signs, level of consciousness, pain level, nausea, and vomiting. We also check urine output to make sure the kidneys are working properly.
So it's a continuation of the vigilance we maintain throughout the surgery.
Exactly. We're watching for any signs of complications. The recovery room nurses are highly skilled and play a crucial role in this phase.
It's a team effort. Now, as we wrap up our discussion of monitoring, I want to emphasize vigilance and attention to detail.
Couldn't agree more.
Anesthesia is dynamic. It requires constant attention to patient safety.
Technology and monitoring devices are great, but they're just tools. It's our clinical judgment that makes the difference.
Okay, let's shift gears now and talk about patient safety. This is always top of mind for us as anesthesia providers.
Absolutely. We're working with powerful medications and procedures. Safety has to be our top priority.
So what are the key principles that guide our safety practices?
Well, we always start with a thorough pre-anesthetic assessment. Checklists are essential. Communication with the surgical team and other providers is crucial. And we maintain a constant focus on vigilance, monitoring our patients, and being ready to respond to any changes.
It sounds like a multi-layered approach.
It is. We combine technology with clinical judgment and expertise to ensure the best possible outcomes for our patients.
Okay, let's dive into another important area, pharmacology. Anesthesia pharmacology is a complex field, but understanding the medications we use is essential for safe and effective practice.
It is a complex field. We're dealing with medications that induce anesthesia, control pain, relax muscles, and reverse the effects of other drugs.
And we use so many different medications in anesthesia. It's like having a whole toolkit at our disposal.
We have intravenous anesthetics like propofol and ketamine, Inhaled anesthetics like sevoflurane and desflurane, opioids like fentanyl and morphine.
Right, and muscle relaxants like rocuronium and succinylcholine, and then there are reversal agents like naloxone and Shigamedex. It's a lot to keep track of.
It is. We have to understand the pharmacokinetics of each drug, how it's absorbed and eliminated by the body, and the pharmacodynamics, how it interacts with the body to produce its effects.
So it's about more than just knowing what the drug does. It's about understanding how it behaves in the body.
Exactly. And we also need to be aware of potential side effects and drug interactions, especially when we're using multiple medications.
It's a complex and challenging area, but mastering it is essential for providing safe and effective care. Now, let's look ahead to the future of anesthesia monitoring. What exciting developments on the horizon? What new technologies are you most enthusiastic about?
Anesthesia is constantly evolving. It's a really exciting time to be in this field.
What advancements are you most excited about?
One area I'm particularly interested in is closed-loop anesthesia delivery.
Closed-loop anesthesia delivery.
Yes, imagine a system where sensors continuously monitor the patient and automatically adjust the anesthetic medications to keep them at a target level of sedation.
That sounds amazing, like an autopilot for anesthesia.
Exactly. It has the potential to revolutionize how we deliver anesthesia, making it safer and more precise.
What other advancements are on your radar?
Non-invasive monitoring techniques are also very promising. Near-infrared spectroscopy, or NIRS, is showing great potential for monitoring brain oxygenation. And wearable sensors are being developed that can track a wide range of physiological parameters.
So the future of monitoring is about less invasive, more personalized, and data-driven care. It's an exciting time to be in anesthesia.
It is, and it highlights how important it is for us to keep learning and growing throughout our careers. We need to stay on top of these new developments so we can provide the best possible care for our patients. It really is. It's like we're always piecing together a puzzle, understanding how each medication works and how they all fit together.
And the more we understand, the better we can care for our patients.
Yeah.
So let's talk about the future of anesthesia monitoring. New technologies, new techniques, what's on the horizon? What are you most excited about?
Oh, there's so much happening in anesthesia monitoring right now. It's a really dynamic field. The future is all about less invasive monitoring, more personalized care, and using data to guide our decisions.
Can you give me some specific examples? What advancements have you particularly excited?
Well, closed-loop anesthesia delivery is something I'm really interested in.
Closed loop. Tell me more.
Imagine a system that continuously monitors the patient's vital signs, their brain activity, everything. And then it automatically adjusts the anesthetic medications to keep the patient at just the right level of sedation.
Wow, that sounds incredible. Like an autopilot for anesthesia.
That's a great way to put it. It could really revolutionize how we deliver anesthesia, making it safer and more precise.
What other innovations are you keeping an eye on?
Non-invasive monitoring techniques are also really promising. Near-infrared spectroscopy, or NIRS, is one example.
I've heard of that.
It can be used to monitor brain oxygenation without any invasive procedures.
That's amazing. So we can check on the brain's health without having to do anything invasive? What else?
Wearable sensors are another exciting area. Think about it. Patients could wear sensors that track their vital signs, the depth of anesthesia, all sorts of things.
That would give us so much real-time data.
Exactly. We could detect subtle changes and intervene early, before problems even develop. And we're not just talking about vital signs. New sensors are being developed that can measure things like tissue perfusion, drug levels, even pain signals. The future of monitoring is all about getting a complete and detailed picture of the patient's physiological state.
It sounds like we're moving towards truly personalized anesthesia care.
We are, and that's what's so exciting about this field. There's always something new to learn, something new to explore. It's a constant challenge, but it's also incredibly rewarding.
Well said. It's been a fantastic deep dive into the world of anesthesia monitoring. From the basics to the cutting edge. We've covered a lot of ground today. I'm sure our listeners have learned a ton.
I hope so.
So as we wrap up, what's one key message you want our listeners to remember about anesthesia monitoring?
Anesthesia is a team sport. It requires communication, vigilance, and a constant focus on patient safety. We have amazing technologies at our disposal, but it's our clinical judgment, our expertise, and our commitment to our patients that truly make a difference.
Perfectly put. Thanks for joining us on this deep dive into anesthesia. We'll be back soon with another exciting exploration of a different medical topic. Until then, stay curious, keep learning.